Welcome back to the Miller Center's webinar series. Today we're looking at healthcare and the coronavirus pandemic. The COVID-19 outbreak has tested and will continue to test the resilience of hospitals and public health systems. That's certainly the case in the United States, but it's also a global phenomenon. Here at home, hospitals have been running on short supplies. Masks, gloves, face shields. PPE may now have entered the great American pantheon of acronyms. US hospitals have waged bidding wars for respirators and ventilators. Testing remains in short supply. Who tests? Who gets tested? How quickly to process the results are all critical. Then there are hospital beds. Despite high healthcare spending, the US has fewer hospital beds per capita than most other wealthy developed nations. That's meant very little excess capacity in the hotspots of the crisis. Politicians are looking to patch deep-rooted structural problems. Care is free or cheap at the point of service. That's because the government is either covering more of the cost or is mandating private insurance to cover services related to the outbreak. Ironically, the hospitals that are facing the biggest surge of patients are financially likely to benefit the most. Others, which have prepared for a wave of cases, have shut down elective surgeries and other practices that bring revenue. When the wave hasn't arrived due to successful social distancing, those hospitals now face revenue crises. And then there are the hospitals serving low-income or rural communities, which might not be prepared for an onslaught of cases when they arrive. Early data show that poor and minority communities are most severely impacted, not just in illness and mortality, but by the loss of employer-provided health care. This is all being replicated overseas. The pandemic is working its way across the industrial world and now starting to affect poor countries. In Africa, for instance, everything from PPE to ventilators to ICU are limited. They are being helped by a generally young population, which will work in their favor, and also because those countries have less international flow of people and a less internationally mobile population. China has already expanded its economic influence in many of those countries, with now one Chinese billionaire, Jack Ma, who's donated test kits to Africa. South Africa has the most cases right now, with lockdown and travel restriction orders. The industrial sector is being given incentives to assist with needed medical supplies. And then there is the World Health Organization. President Trump has announced cuts to WHO funding as a result of accusations of being China-centric in its policymaking. The United States in the past has provided the agency with $893 million during its current two-year funding period. Funding varies from year to year, and the Chinese contributions to the WHO are only a fraction of that. The president here has piled on to rising conservative criticism of the WHO, which is paired with his criticism of China as being deceptive and defensive during the crucial outbreak early periods in China. So to help understand how all of these healthcare dimensions to connect, how the US connects to the healthcare response around the world, we have two terrific experts here at UVA. First, Guian McKee is an associate professor of presidential studies here at the Miller Center. His areas of expertise include health, law, justice, race and racism, and social issues. Guian has written about healthcare in a variety of venues, many of which have explored cost as an imperative but frequently overlooked component of health policy, and the development of hospitals as drivers of cost in the larger healthcare system. He has wide-ranging knowledge of healthcare policy, its contradictions and challenges, and how it plays out at the local community level in American cities. His work traces the intersection of healthcare to urban policy and of the healthcare sector to wider changes in the American political economy of American cities. And then we have with us Katie Quissell, who is an assistant professor in UVA's Department of Public Health Sciences. She is a political scientist by training with expertise in global health policy and health governance in the lower and middle income countries, and how governments, non-governmental organizations, and advocates shape which issues receive attention and how sound policy is designed, adopted, and implemented. Katie's work focuses primarily on Eastern and Southern Africa. Her current research investigates why certain global health policy networks are more effective than others in garnering resources and attention for their issues, how the characteristics of health issues and target populations influence the scale up of infectious disease treatment programs in low and middle income countries, and under what circumstances we are more likely to see cross-national policy divergence or convergence with global policy recommendations. So Guian and Katie, it's great to have you both with us today. Really looking forward to this conversation, which is an area I like to say, similar to Middle East policy, I know almost nothing about and therefore am dangerous. And so let me start with Guian with a bunch of questions about the US situation. First, Guian, why were our hospitals seemingly so unprepared or underprepared when the crisis first reached our shores?
Sure. Well, first of all, thank you for having me today. The other thing I'd like to say just off the top, nothing that I have to say today should be seen as a criticism of the people actually working in our hospitals today amidst the crisis. There's a lot to say about systems and history, but we also need to recognize those sacrifices and really celebrate those. I think to answer your question, Bill, we have to really step back to those systems and really look back at the history of our wider healthcare system. And, I would go back 100 years, 120 years, the turn of the 20th century. And at that time, the United States really had a pretty robust public health system, at least in some big cities, New York City, Boston, Baltimore, for example. Public health systems that had the capacity to deal with the disease outbreaks of the time, things like cholera, tuberculosis, yellow fever, all of the communicable diseases that plague people really all through human history. And along with sanitary reforms, those public health systems really made significant progress at that time in controlling disease outbreaks. Not, of course, completely successfully, but there was a capacity there that was pretty robust and pretty vibrant given the scientific understanding of the day and medical capacities. There was always a tension, though, in public health in the United States, and that lay on the lines or the division between identification of disease and its treatment. And the extent that public health veered over into the area of actually treating disease, there was a threat that it posed to organized medicine, particularly as expressed to the American Medical Association and state medical associations. Organized physicians were always resistant and to some degree threatened by the expansion of public health into treatment areas. So there was pushback and there was resistance to expanding those systems into the development of things like comprehensive healthcare centers, which is a major public health movement in the 19-teens and 20s. And this would have actually put physicians to work for public health departments in major cities, or even at the county level in more rural or smaller communities. This was something that organized medicine was threatened by. They centralized the private practice of medicine, the independence of doctors, and this was about the sanctity of the doctor-patient relationship. They didn't want anyone potentially controlling treatment. And it was also about the economic viability of physicians. There's a longer story here. Over much of the 19th century, physicians had wanted autonomy and professional authority over medicine, which had been challenged in many directions. So there was a long struggle that was behind the AMA's position there. So that's point number one, that there was always a limit on public health. The second thing that happened is that beginning in the 1930s and then extending into the 40s, a kind of society-wide decision was made to emphasize the hospital as the locus of medical treatment in the United States. Technologically intensive, and also, this is a critical point too, capital intensive institutional structures, as opposed to things like the kind of comprehensive health centers that I mentioned a moment ago. After World War II, 1946, Congress passed the Hill-Burton Act, and this essentially provided federal matching grants for the construction of hospitals around the country. So you get a process of building out hospitals in many small cities and towns around the country. And that's kind of the basic infrastructure of our hospital networks today. But a couple things changed, beginning really in that post-war period. As private, employer-provided health insurance starts to spread, the private insurers start a practice of reimbursing hospitals for their capital costs. That is the costs that are necessary when you add new machinery or when you build a new hospital wing. And when Medicare and Medicaid passed in 1965, the congressional leadership and the Johnson administration, they've been fighting, for literally 15 years to get Medicare through. The last thing they want is a fight with physicians and hospitals as they try to implement the bill. So essentially, they adopt the same standard of reimbursable costs that includes reimbursement for capital costs, depreciation, interest, and a 2% allowance essentially for those capital costs. This creates an incentive for hospitals to start funding expansions through going into the debt markets, essentially taking on tax-exempt bonds if they're not-for-profit, and to engage in competitive practices to raise the revenues necessary to support that capital strategy. And the effect of that, particularly as Hill-Burton goes away in the 1970s, is that you put hospitals in a situation where they're forced to act as competitive businesses, that every hospital has to support not just its operating costs, but its capital expenses as well. To do that, you need to drive revenue. To do that, you've got to have the newest facilities, the newest technology. And there had been limited planning of the overall system under Hill-Burton, not very good or very strategic, but there was some. But in this kind of competitive situation, particularly as it evolves in the ensuing decades, hospitals are posed one against the other. And there's very little capacity to do even region-wide planning, let alone system-wide planning.
So
Right.
Guian, I'm curious if that ties back to beds. It
Yeah.
strikes me that as you're talking, right, if you're in a situation where you're setting up hospitals to compete with one another, essentially on a combination of fee for services and profitability, you're going to want to operate like a hotel where you're maximizing your occupancy, but that means not so much surge capacity. Or am I hearing you wrong?
Yeah, absolutely. That there's really no way in this kind of an environment that hospitals can carry excess surge capacity. So that's part of it. But there's a second dimension. When we look sort of at our overall national health spending, the emphasis over time had gone into hospitals rather than public health. So you end up with sort of, on the one hand, pressure to cut back on hospital costs. So we've actually seen, for a lot of good medical reasons, a reduction in hospitalization rates in the most recent decades, and particularly in the last 10 years or so, cut back in the number of beds. And that's a positive thing overall for healthcare costs nationally, but it has made this situation more challenging. But we also have the worst of all possible worlds in this sense, because our emphasis over the last 75 years has been on hospitals. We've massively underinvested in the kind of public health systems that would have both planned other ways to deal with surge capacity for beds, first of all, but all of the other things that we've been so lacking on during this crisis, whether it's testing materials, whether it's protective equipment for healthcare workers. So that's really the thing I would like to drive home, is that we've taken this course over 75, 100 years that's led us to this position today and the difficulties that we're now facing. And then, of course, you get into the actual management of the crisis over the last few months too.
And before we do that, let me just ask you one thing. I'm thinking back to the last Democratic debate between Bernie Sanders and Joe Biden. At one point, Bernie Sanders tried to pivot in the middle of the conversation and saying, this is essentially why we need Medicare for all. And Joe Biden's response was to point to Italy's healthcare system, and which at the time was at the peak of the crisis, was being overwhelmed. Deaths were spiking. They were well ahead of where New York ended up being and ended up catching up. And he said, we don't want it like it's happening. We don't want essentially a single payer Medicare for all system. Look how that's working out in Italy. Was that a fair comparison?
Yes and no. There are two pieces of that. See, there's what Sanders is driving at is a valid point in that if you have to finance people's access to care one way or another, and that's one area that we've fallen short historically and to a degree in this crisis too. But you have to separate that from actual capacity issues and delivery, and that's that's the thing. Whether you've got a national health insurance system in terms of your financing of care, or the kind of public-private college that we have, it's very, very difficult to finance surge capacity of things like hospital beds under normal conditions. It's extremely expensive to maintain hospital beds. So this is where you have to have the kind of robust public health planning that has a plan in place that when a pandemic strikes, you know where you're going to put the emergency beds, where they're going to come from. All of these things are lined up ahead of time. That's really the thing I would drive home. And it's helpful to have everybody covered and know how they're going to pay for their health care, certainly, but that doesn't solve the capacity issues. For that, you need robust public health.
So we're essentially slapping together a public health system around a hospital-based and doctor-based healthcare system. Yes. While this is happening. As it's unfolding, and I really want to encourage the audience to start submitting your questions for Guian, and we'll come back to Guian in a second. But one last question for Guian before going to Katie. We're putting together this public health system around a largely doctor and hospital-based system, health system. What are you watching to see as it comes together, both at the local level and at the national level? What seems most relevant to you as an indicator of a successful slapdash effort to build a more robust public health response?
Yeah, I think honestly, the markers for that will be in the coming months, whether we're able to do soft reopenings of society successfully. That's the ultimate test. To do that, we're going to need the capacities, as has been widely commented on, to do almost population-wide testing, or certainly of vulnerable populations, both of actual disease identification, but also antibodies. And then also to have the plans in place where we do get surges, as we do get second waves in particular places, that we can rapidly deploy the equipment, the hospital capacity that we need, such that we can move back to, if not normal life as we knew it before, at least some degree of greater societal function. That's really what's at stake here. How long do we have to do this kind of hard shutdown?
Thanks, Guian. Let me turn to Katie. And first, Katie, welcome again. It's great to have you as part of the Miller Center's webinar series and to have you with us for the first time. Your knowledge, particularly in Africa, is fascinating. On the one hand, as Guian is pointing to past the peak and how we get back to normal, but right now, the peak is just starting to arrive in these other parts of the world. They're poorer, they have less well-developed both hospitals and maybe public health systems on the one hand. On the other hand, they do have experience with infectious diseases. So tell us a little bit about what you're watching as the disease rolls south.
Absolutely, and thank you again for inviting me to be a part of this conversation. I've been looking forward to it. So with that question, there are several things that I'm looking at and continuing to follow, and there are some issues which I'm very concerned about and are keeping me awake at night. Others where I do have some optimism, having seen the degree of mobilization around the continent and specific countries that I do think we might see more effective mitigation than we initially anticipated. So perhaps I'll start with some of my areas of concern and then talk about some of what I see as strengths within the healthcare systems. So one way of, I think, organizing my areas of concern, there's this really interesting political analysis by a comparative politics scholar that was published on the Duck of Minerva blog. It's kind of a dorky public or political scientist blog. So I highly suggest reading it for more in-depth information on this, but basically she had looked at some initial country cases of these sort of strong and weak responses, and was looking for particular factors that might explain what we're seeing. And so some of these, again, are raising concerns for me when I look at African countries, and some of them are also areas of strength. But what she found was that the regime type actually doesn't matter very much, that we've had strong responders who are more authoritarian, some democracies have done better than others, and that really what it was 3 factors in combination. So the first was related to central state capacity, and this had to do with infrastructure and effectiveness of the public administration within countries. Overall leadership, and the idea here is that even if you have strong state institutions, if you don't have leaders directing them and mobilizing them, you're going to have weaker responses. And the third is this issue of state-society relations. And here is the idea that if you have significant buy-in by citizens, by local communities, and trust in leaders and institutions, if the regime has legitimacy, then you're likely to see citizens following government decisions. So it's this combination of factors that I guess with these early cases, largely in Asia and in Europe, that have pointed to strong and weak responses. So when I look across African countries, the areas that concern me have to do with state capacity for some of the reasons that you mentioned, both in terms of the ability to mobilize weaker health systems infrastructures. And here it's really talking about medical care infrastructures, because many of these states do have quite robust public health systems, which they've developed out of necessity. And I can talk more about that when I get to what I see as some of my points of optimism. But if you look at some of their prior examples with infectious disease outbreaks like Ebola in West Africa, earlier on in those responses, you saw significant levels of distrust. So the state-society relationships can be concerning. There were attacks against healthcare workers, distrust of government information. And so there certainly was a lot learned in those countries given that experience, and a lot of important work done on how to more effectively work with communities and mobilize community leaders to be more effective messengers. And they've also clearly improved surveillance, contact tracing systems, and things like that through their experience with diseases like Ebola. But you still have many countries where government distrust is high, and where you've not necessarily seen engagement with community or more local leadership. So that's an area of concern. What you've been mentioning in terms of their supplies, there have been strides made to improve both their laboratory capacity. I think when this outbreak first began, there was something like 1 laboratory in the entire continent that from moment go could test for this coronavirus. And so they now have at least now, I think it's like 42 state labs, in addition to other private labs who are able to do testing. But they still have significant shortages in ICU beds, ventilators, other supplies for getting patients oxygen. And what we're seeing right now is that because you've also seen at the global level, this kind of every state for themselves in terms of how you get equipment, that they've been competing with higher income countries for these ventilators or for other technologies, and they can't beat out higher income countries. They don't have the same financial resources to leverage when it becomes to a bidding war or price gouging. We also know that limited access to water and soap is sanitation problems are gigantic, as well as access to healthcare more generally. And we're also seeing in other countries, the trend is that urban areas, higher density populations are hit first, and they certainly have those in the African continent, especially when you look at slums and townships in major urban environments where you might have multi-generational families living together, overcrowded living conditions, shared taps and toilets. The other factor I'd point out too is that we don't know yet how coronavirus interacts with malnourishment or immunocompromisation from HIV or other infectious diseases, because we don't have as much data from the African continent as we do from other countries. So if you look at it then, spinning to the points of optimism, they don't have the same chronic disease burden. They don't have the same extent of diabetes and heart disease that we know are really troubling. Pre-existing conditions that make people susceptible to more severe illness. They have less population density than Asia, certainly. They also have, as you mentioned, a much younger population. Only about 2% of the population is above the age of 65, as compared to 23% in Italy. So younger populations, lower disease burden of chronic infections will certainly help. And they do have a tremendous amount of infectious disease experience. For example, it's hypothesized that Nigeria was able to quickly stamp out Ebola because of their polio surveillance capabilities. So we know that they've also had a lot of experience with case finding across the continent and contact tracing because of Ebola and HIV and tuberculosis and these other infections. And so they are able to mobilize pretty strong public health systems, which again, they've invested in out of necessity because it's prevention based. It's also more cost effective and is cheaper than some of the higher technology medical care. They also are really good at task shifting and using lower level clinicians, relying really heavily on nurses and other types of clinical professionals to extend healthcare resources outward. Many countries have already had in place tens of thousands of community health workers that they could use to do contact tracing or mass testing. So they have a lot in place. And then also following Ebola, there was more investment in coordination across the continent. They now have, sort of a Pan-African Center for Disease Control. They've been really engaged with the global influenza network, which has been managed through the WHO. And the WHO has been providing a significant amount of technical assistance to help them build up these capacities. So they've had more time. They've been able to plan. You still see a lot of variation across the continent in terms of which governments have ordered lockdowns and strict social distancing. And so we'll see how that ends up happening. But also this is a large generalization.
Let me jump in there and ask you a question about the WHO. That
Please.
last example you pointed to, I would say, was sort of long-term systemic infrastructure advice. Can you give it just, when the Trump administration or conservative critics are going after the WHO, presumably that's because of things the WHO said and did as the crisis was unfolding. Just give us a sense of the role the WHO plays sort of as a spectrum. How much is it long-term structural and how much is it as an air traffic controller in fighting a global pandemic?
Yeah, absolutely. So a lot of the work that the WHO does is in the longer term health system strengthening, providing technical assistance and capacity building to low and middle income countries. That's its bread and butter. That's most of the work that it does. When it comes to pandemic disease and response, that is based under the International Health Regulations, which is one of the major global health treaties that the WHO is responsible for guiding the process. So that really only comes into play with both the reporting of an outbreak, but they also run, global surveillance systems and try to maintain certain capacities to make that system and that structure function. So when you look at, what they're doing right now related to the pandemic, they're in a really fundamental coordination role in terms of trying to build global cooperation, information sharing, transparency. They also have been playing a gigantic role in technical assistance to the African continent, for example. And they're coordinating some of the world's largest clinical trials related to treatments and vaccines.
Got it. Let me pull Guian back in here and get some thoughts from both of you. First, I want to look at a little bit in a global comparative sense, since you both have made some global comparisons. As you look around at other countries responding in the day-to-day, there are two pieces to this, right? There's the day-to-day response and the structural system. What are the most effective day-to-day emergency responses you're seeing out there? Particularly still, since we're still in the rising part of the curve here. I mean, some places are peaking, but most of the country is still rising. What are the lessons learned from other places that you think we should be responding to?
I would probably point to somewhere like Germany as a good model. They had certain advantages, I think, in their preparation being better, but they had fairly effective shutdown period, stay at home, and they are now moving to the kind of broad-based population testing to ensure the capacity to carefully move back to reopening. That would certainly be a model. I think you're seeing that in a few other places. Spain is doing some of the same, although I'm not sure their preventative or their testing capacities are quite at the level of Germany. I guess the thing I would probably emphasize is that because we're still where we are in the curve, we will have the benefit of other countries' experience to learn from, although we have very little time to learn from it and to mobilize.
Mm-hmm. Katie, are you seeing good examples of positive steps taken that can be replicated here?
Yes, I think that the common thread is mass testing across countries, and you saw that Germany and South Korea in particular. The reason why that's so useful is that they've been able to find more mild cases and then keep them isolated and keep them from infecting other people. So not only does that reduce the reproductive rate of the virus, the disease, they've also been able to get people into care earlier. And so there's some information out of Germany that suggests that even for more mild cases, if you can get them into medical care more quickly, you can potentially prevent the deterioration that we're seeing. So again, this is very early evidence, and I'm not sure if it's going to be confirmed that that's the case, but that's one of the things that German physicians have been suggesting. So, with Germany, they created their own test back in January and they stockpiled it, so they were ready to implement it. They were following WHO guidance for every country to prepare for containment, and that's what they did. And I think with South Korea, you saw a similar response, potentially in part because of their experience with SARS and MERS, that they had these emergency procedures in place, took it very seriously and acted immediately. So I think this idea of leadership responding aggressively and early, having significant preparation in place, and then the ability to mobilize those resources and implement them. And you also, I think, in both of those countries see a good deal of trust in leadership and people following what their government is telling them to do.
I am curious from both of you, and this is a question that comes from Heather Rowland here. As you look across these other systems, we're a federal system, right? So at some level, the appropriate comparative unit might actually be the EU, or maybe Germany at the federal level, or China, though it's not a federal system, it's a central system, but with strong provinces and strong provincial governments. I'm curious to get your take about that. How much should the response on things like testing and PPE be locally driven, and how much should it be nationally or federally driven?
Well, you always have to have local and state level capacity, particularly the local level, to actually do the implementation. I mean, the thing that I would say about a federal system is it does allow a degree of nuance at the state level in terms of response, but it has two weaknesses: that you're always dependent on the capacity and the competence of those 50 or 51, if we count the District of Columbia, micro level responses, how well it's being done, how soon they reopen. And then the second weakness is that you do need federal coordination on critical issues. It's simply nuts that we have states competing, bidding against each other for protective equipment. That shouldn't be happening. It's that simple. And that is where you do need the federal level coordination. Even if your preparation ahead of time was inadequate, there should be systems that are being developed and put into place to allocate resources where they're most needed and to move them rapidly to meet those needs, whether they're testing supplies, whether they're protective equipment, any element of this, even at the level of surge capacity in hospital beds, as we talked about. That is the role the federal government needs to play, and it's been lacking so far.
Katie, you've tracked so many different countries, and some of these African countries are massive, right? Nigeria is, it's close to 200 million people now, with a strong federal history, including having had a regionally based civil war years ago. But I'm just curious, when you hear that, and Africa itself, a continent of close to 1 billion people now, when you hear that federalism issue, does that Does that ring true to you, or is it just, is it really still about national systems at some level?
I think that what seems to be key in this response is the extent to which, and this I think kind of mirrors what Guian was just saying, the ability for central authorities to help in terms of mobilizing and ensuring access to supplies and materials, and that there seems to be a need for clear and consistent communication and steering of multiple actors. And so that's where having central government with some capacity for those functions is important. That doesn't mean necessarily that more heavily centralized countries will always do better. And I think this is something that we should look to, because even with Germany, I think the chancellor also spent quite a bit of time working with the leaders of like the subnational jurisdictions to get everybody on board and operating together, so that what they were getting was clear and consistent messages about what was happening, why it needed to happen, and making sure that there weren't unnecessary inequities or fighting over materials and supplies in the midst of scarcity. So I think that helps build this sense of solidarity and togetherness that many of these countries also have more of anyway, just in terms of their own ethical viewpoints. And so I think figuring out how to build off of those skill sets is the important point.
Let me dial that up to another level of generality that comes from a question from Philip Webster, which is how can the U.S. create a national healthcare policy when its society is so politicized between totally disparate points of view regarding healthcare delivery? Guian, you've tracked this issue so closely over so many years, the philosophical issues underlying the difference between what you were describing before, a doctor and hospital focused system as opposed to public health, has a political dimension, but it's now become politicized in presidential politics over at least the last 30 or 40 years, and even goes to differing points of view about the role of government in society and the role of government in healthcare. And I'm just curious to hear how much that translates, how important it is in the US context, but also are these issues as politicized elsewhere around the globe?
On the last piece, no. There certainly are conflicts over the direction of healthcare policy and its nuances, but generally speaking, there's a much greater basis of societal consensus in most other countries. As Katie just said, the capacities of social solidarity are really being reflected in this. As to where it goes and whether we can kind of shift off of the base we've been stuck on for so many years, that's still an open question. I worry a lot about the problem of confirmation bias. That is that, what I might have thought on February 1st is now what I think, is the solution today. And I think in a polarized situation, and one that unfortunately looks like it might be becoming more polarized as we see some of the protests about the shutdowns, there's a danger that people just dig in. That said, this has been a shock to all kinds of systems, political, economic, not to mention healthcare, and shocks can knock things off of that kind of basis. I guess if I find some hope, it's that we might start talking about issues of the healthcare system on a broader conversation than just the one of, do we have single payer, or do we have a public option, or do we rely on market mechanisms? These are deeper questions than just the financing of care, as crucial as that is. Questions of what is our society-wide disease response capacity and planning? What is the nature of our delivery system and the payment mechanisms for providers? These kinds of questions are complicated. They're difficult too, but they change when we bring them in. They might have the capacity to help us change the conversation, and particularly with the costs that we've seen from this tragic, terrible episode, there is at least some hope that we might come up with a better future out of it.
Let me ask a follow-up question to Guian and then turn to Katie on how, again, the politics play out globally. But in the US, right, we, on the one hand, as Stacey Baker suggests after 9/11, for instance, in the early 2000s, we had a big surge of funding, in preparation for bioterror and things like that on the one hand. On the other hand, we could have hospitals fail as a result of this, the emptying out of beds, the fact that hospitals doing the right thing might get penalized and hospitals that get overwhelmed might be structured very differently. And the president himself essentially saying, if you're a COVID patient and you go to a hospital and you're not insured, we're going to give you Medicare coverage. So essentially he's provided Medicare for all. Have tectonic plates shifted already in the system such that we have to have a structural shakeup?
Yeah. The tectonic plates were already shifting. I mean, we had rural hospitals and to some degree weaker inner city hospitals that were already financially threatened. They're talking about building out the system under Hill Burton in the post-war decades. We put a lot of hospitals into communities that have had demographic declines and economic shocks, and there was already great weakness in a lot of those systems. And there may now be hundreds of hospitals whose very survival is at stake. But the interesting one, as far as that last point, once you've said that we should pay for treatment for COVID-19, there is kind of at an ethical level, why is this different than other healthcare costs? Why is it a right to have this covered when we don't cover cancer treatment necessarily, or preventive care, or whatever it might be? And that's where we get into this question of the unknowns. Once these kind of shifts have happened, does the playing field look different when we come out of it? It does sort of bring basic features of the discussion that may have been obscured to bear. We haven't even talked about the emerging disparities along lines of race and ethnicity in terms of infection and death rates. That's a whole nother one that is very much bringing to light existing problems and inequities in our system and in our society.
I definitely want to come back to that. Katie, are the politics this nasty around healthcare in some of these other countries? And do you get, if they are, do you get a sense of whether the pandemic is changing that in those places?
Well, I'd say my generalized statement on it is that there are politics involved in every healthcare system, but for many, they have at least agreed on the foundational principle that healthcare is a right of all citizens, and the arguments are more at the margins. And it's much more about how do we balance and fix certain tensions or certain problems? Do we introduce more competition and market mechanisms within this, still recognizing that to ensure access and for all, that you treat healthcare more as a public good as opposed to a private good. So I would say that a lot of these decisions are political because they're controversial. It has to do with things like rationing and redistribution, and that's political everywhere, but they've at least have that common understanding that healthcare is a right.
Mm-hmm. So again, that's maybe a good tie back to the US system and those issues that you raised. Often we're hearing the argument that healthcare is a right coming from the left in the United States, and particularly a concern about minorities and poorer served communities not having access to the right because it's so much based on the ability to pay, tied to employment, tied to health, employer provided health care. Do you see that changing? Do you see an expanding scope? As one viewer asks, do you see the US system changing such to have a broader understanding of who can and should be covered in these events? And is COVID going to change that, particularly because minority and poorer communities seem to be suffering the most, higher death rates, higher infection rates?
Yeah. There's certainly a model, kind of as I alluded to in my last set of comments, when an episode like this exposes inequities and injustice, at our best, we respond to that and solve that problem. And that's kind of the model that sees a tectonic shift here and the politics go towards, whether it's a Medicare for all system or some kind of a nuanced, expanded public option. model. There was a great piece in the Times by Jacob Hacker, one of the leading health policy scholars this weekend, saying, well, Elizabeth Warren's second plan is actually the most viable one forward. And there's an argument for that politically. And that's,
let me guess, he was one of the authors of that second plan.
He was indeed, yes, yeah. So that it can break in those ways. But I'll throw out another, and this is another.
Don't trust those Yale political scientists.
Yale political scientists. Exactly. Yeah. They're always there. Anyway, Bill got his graduate degree. Yeah, everybody. That's the joke there. But in any case, there's another scenario that I'll throw out here, and this is really the tectonic plates shifting, or everything we assume getting scrambled. There's a way we assume that these kinds of strong public systems, whether it's healthcare or a social welfare system, a safety net, writ large, are issues of the left. That's not automatically the case, though. And I can see another model where you see the sort of nationalist forces that have emerged in conservatism, by no means, despite Trump, dominant yet, actually latching on to some of these issues. That nationalism might involve things like, on the economic side, strengthening domestic supply chains, moving out of that kind of globalized supply model, but also a kind of solidarity around the nation that includes basic social supports. We see inklings of this from a number of people on the right now, even in the Senate. And it's by no means dominant. It's by no means certain that this is what comes out of it, but it's one possibility. And, a smart and skilled politician might actually, over the next decade, implement exactly that kind of a synthesis around nationalism in very unpredictable ways and with all kinds of unforeseen consequences. Don't get me wrong, I'm not necessarily predicting that outcome, but I think it is one possibility that we have to keep in mind when we talk about where this might go, whether it's Medicare for all or that kind of broadened nationalism.
Katie, you've seen the pandemic now move through a number of industrial countries globally and now moving to the developing world. Are you seeing shakeups in the way the industrial countries' health systems have responded to as a result of the crisis and how they've responded? I know it's probably too soon to say in the developing world, but I am curious as to whether there are tectonic plates moving in some of these other places.
Honestly, right now, from what I've seen, is that everybody is in a similar situation of figuring out how to mobilize additional capacity, how to build field hospitals, how you expand ICU beds. And then I think it's also very much been about how do you utilize core public health tactics like the contact tracing and notification of contacts and isolation. And so right now, when you look at some of the financial concerns and systems, it's unclear how, say, like hospitals throughout the EU are faring in comparison to those in the United States. But if you do have, again, more centralized healthcare systems, you also have the ability to move resources around a little bit more quickly in response to what areas are being hit harder. So you can have greater coordination, sort of shifting and redistribution taking place. So we'll see. Again, I think it's too early to see about the impact on like the medical care system in particular, but at least for most of these countries, citizens haven't had to second guess or question whether or not they're going to face financial consequences of having to go seek care. So pretty much across the board, these systems have said not only are we covering your testing, but we are covering any sort of treatment that you would need. And so there's not the same level of financial concern, which is very useful in the middle of a pandemic. You don't want people not going in for care out of concern for cost. So I think we'll have to see what the costs end up being to systems, because some of the estimates coming from the US right now are pretty shocking. I think there was a recent study that looked at what it might mean for increasing the cost of private insurance by 40%. to cover these costs that are being spent right now. So, I think that all of this, the financial questions are gigantic everywhere, and it's still uncertain what it's going to look like.
I'm curious to you both. John Smith sends in a question. How does our current pandemic response compare to the response in 1918? Have we learned from that and anything? And are we applying the lessons learned? And I'm curious for both of you. It was a global pandemic. It's called the Spanish flu, even though it's unclear whether or not it actually started in Spain. Guian, you gave that historical context. I'm curious on the US side what we've learned, but Acadia was global, and it really did shape a number of European systems at the very least, but perhaps in the developing world. So either of your thoughts on the Spanish flu and how its legacy affects the current pandemic?
I think what I've been seeing as mostly the reference to that in terms of these discussions over lockdown, because I think some of the data that came out of that pandemic were the areas of the world and the areas of the United States that were slowest to close businesses and schools didn't fare as well. So I think that information has been shaping decision-making around what to close and when across a lot of different places. Guian, I don't know if you have anything else to.
Yeah, no, I think that's exactly right. And there's even some data that their long-term economic recovery was better, where they had more effective shutdowns, longer shutdowns, to the point they actually had less disease impact over the course of the pandemic, and then better economic recovery. The other thing I would say, and there's been less discussion of this, but there was, at least in the US, there may not have been enough learning from that experience. There was a desire to move on, to forget it, to get back to normal life. And it was the period that came after the Spanish flu that we really moved out of kind of the golden age of public health in the United States and more towards that medical and technologically intensive model that I discussed earlier. So I think that's going to be one of the real questions, is what kind of societal learning comes out of this experience, and do we make some of those things that we've been discussing better over the next 10 years, the next 20 years?
So an open question to you both that comes out of that. I was struck in some of the things that I read about the after effects of the Spanish flu were really cultural, social, ethical, how people thought about interacting with one another. There was almost a silence in some places about the fact that people avoided one another when they were in moments of crisis. And my question is even a little broader, which is, as you get trained in public health issues, how are the ethical, social, cultural dimensions part of the training, or the lessons from previous pandemics, part of the training for how one thinks about these bigger moral questions? The trade-offs, the intergenerational trade-offs. I'm just curious, how the left and right sides of the brain are managed as one learns to be a public health official.
I can tell you from my own training, and also what we do within the Masters in Public Health program here at UVA, is there actually is quite a bit of an emphasis placed on ethical decision making, because so often you find yourself in these trade-offs. We always joke that it's like trolley problems all over the place, where you have to figure out very quickly, how you allocate scarce resources and do so in such a way that is equitable, utilitarian and justifiable to broader audiences. And so I think because that's what so many public health problems look like, it's a key component of public health education, particularly how we do it here at UVA. So I haven't used the 1918 flu as a case study in my classes, but with my undergraduates, we do a case exercise looking at Ebola in West Africa as the context. But you see that oftentimes the types of decisions that have to be made are somewhat similar.
Mm-hmm. Guian?
Well, the only thing I'd probably add is, I guess, it goes beyond public health schools and professionals, and the capacity to have more informed public discussions of those kinds of very difficult trade-offs, so we don't get into some of the kind of very simplistic and counterproductive exchanges that we've been having in the United States over the last week or 10 days, which have been pretty dispiriting, I think. That there are real trade-offs that we have to think about, but they need to be done in nuanced, informed, and ethically conscious ways.
I'm curious to get both of you, as we're winding down with about 5 minutes left, and thanks to all the audience members who have sent in questions. I am really quite struck in the US, and Katie, I'd be interested in hearing this internationally as well, at how much the voice of business seems to go against a libertarian approach. Businesses, as they consider reopening, are looking at questions that feel very public health management, tracking and tracing, safety of workers, safety of the supply chain. And I'm struck by that, Guian, and I'm just curious to get your own reactions as we move to questions of opening, the role that the private sector plays in shaping these decisions.
Yeah. Well, the reality is, remember back during the Iraq War, I don't know if I've ever, quoted Donald Rumsfeld quite this approvingly, but he made a comment to the effect of, you don't go to war with the army that you wish you had, you go to the war with the army you have. And that's the reality, is that in the United States, we have an associational public-private system. And we simply lack some of these large-scale capacities on the public side that others have. And the reality is that we have to rely on those private sector leaders to both make effective and appropriate choices, but also, frankly, to exert their weight on perhaps more recalcitrant governmental figures to develop that kind of effective response as we move forward. So I think it's simply the reality of the world that we're living in this country. And maybe to some extent, in any country, you're always going to have that kind of coordination across sectors, and there are always going to be that kind of micro level decisions that have to be made.
Katie, your own view, particularly looking around the world and in the developing world, where oftentimes corporations, we have one question who says that in Guatemala, powerful corporations and families have a stronger control of the state agenda. I'm just curious, as you look around the world, has the private sector been a force for effective management or for stymieing an appropriate public response?
I think I've seen a combination of things. So in many of the countries in which I have worked, and this also applies across Europe, there's been a stronger history of labor organizing. And so workers' interests, I think, are also better represented for formal workers. So there is a problem of informal labor in the African continent. But from what I've seen, for example, in South Africa, is a lot of these private sector companies have turned toward the production of necessary goods and equipment. Everyone is trying to figure out how to address the PPE shortages or the ventilator shortages. So I've seen a lot of very good examples of changing production strategies, of ensuring greater worker protections, and of being much more collaborative. And I think that's the key issue here, is that in the midst of a pandemic, greater collaboration is what is necessary across all sectors.
That's great. So we're approaching the end of the hour. I want to thank you both. I'm going to ask you one quick final question, lightning round, 1 minute responses, and then we'll draw this to the close. And that is, moving forward, one recommendation. It can be big or small, but we are at a moment where Congress is passing trillion-dollar bills. And sometimes the slightest nudge in one direction, philosophically, policy-wise, in the writing of something massive, both domestically and internationally, can have a dramatic impact. What single payer or fee for service in one system or another could. So if you had to fix one thing, what would it be? Start with Katie, and then I'll go to Guian.
All right, well, I think I'll keep this at the global level, since that's what I've been discussing. And not that I know exactly how to implement this, but my biggest concern right now is the breakdown of collaboration in terms of global health governance. Every country for itself is not a winning strategy in the middle of a pandemic. And I think we also have to think about it from the US perspective. You know, what are we going to do if we're not the country that develops the first effective vaccine or treatment, but we have not been working collaboratively with others? How are we going to guarantee access? No one country can tackle this on their own. And if this disease is anywhere in the world, it's everywhere in the world. And so we need to figure out how to get everybody sharing information better and working together to address this.
Ian?
I think I'll go back to the starting point, and I'll say a restructured hospital system in the United States that involves more planning and coordination of capital investment in close relationship to our public health structures. Really more, I think, of a long-term fix than something that's going to get us out of this crisis, but to start thinking more systematically in those kinds of ways.
Well, thanks to you both. As one viewer sent in that they could have listened to you both for hours, and I could have as well. I really appreciate you both joining us today. And for the 200 plus people out there who joined us, thank you too. We've really enjoyed putting these webinars together and hope you'll keep coming back. And thank you for tuning in and for your ongoing support of the Miller Center and the University of Virginia.